Dr. Faisal, we can, I think, start. And before you can start your session, can I please give your introduction to our participants?
Yeah.
Okay, so I would like to welcome Dr. Faisal Jafar, and I would like to welcome all of you. Welcome back to our online lecture series. And Dr. Faisal Jafar graduated from Balan Medical College, Quetta, completed his anesthesia residency in FCPS from AKU and cardiothoracic anesthesia fellowship from Prince Sultan Cardiac Center, Riyadh, Saudi Arabia. He's an FRCA and currently working as consultant anesthetist at Western General Hospital in Edinburgh. He's also affiliated with Southeast of Scotland School of Anaesthesia and University of Edinburgh. His areas of interest are major complex urological and colorectal surgeries, including robotic surgery, trauma, orthopedic, and regional anesthesia. But this is not the only recognition of his. He has also secured Berkey Gold Medal in FCPS anesthesia, which is awarded to a person who tops the anesthesia, not only anesthesia, but among all the subjects which are being presented in by College of Physicians and Surgeons, Pakistan. So he's one of the gold medalists as well. So I would like to welcome Dr. Faisal to the PSA Karachi lecture series. Thank you for inviting our invitation and giving us a talk on this such important topic. Thank you. You can please start.
Thank you very much for the kind introduction, and I'm really thankful for this invitation. With the next hour or so, I'm just going to discuss a couple of things regarding the EEG monitoring and the depth of anesthesia monitoring, and the general kind of skills required for interpretation of those waveforms by a general anesthetist. First of all, I don't have anything to declare. There's no conflicts of interest, but just to let you know that I'm not a neuroscientist, and therefore most of my talk is actually based on the studies or the talks based on the other gurus of this topic. And the basic objective of this talk is to give you a bit of understanding what the depth of anesthesia monitoring is, and especially looking at the different waveforms that give you some insight, and also give you some knowledge of troubleshooting if you have encountered problems. So this is the outline of my talk. First of all, I'm just going to discuss a little bit about that why the depth of anesthesia monitoring is essential or required for during this age of anesthetics, and then we'll talk about a little bit of physiology and some of the EEG terminology used. And then we'll discuss a couple of specific scenarios, and then we'll summarize the talk at the end. So it's a kind of a logical thing to think about that if we use the depth of anesthesia monitoring, we could have certain benefits, like we could reduce the awareness, we could reduce the delirium and postoperative cognitive dysfunction, and that might have effect on the mortality and length of hospital stay as well. So although it looks very attractive, but does it backed by the evidence or not? So we'll look into it. So there are a couple of studies done with the last like 10 or 20 years, and some of the studies actually shows that there were regarding the awareness, it showed some benefit in terms of using the best monitoring of the depth of anesthesia monitoring. But the other study shows that there is no difference if you, especially if they use it with the end-tidal volatile monitoring. So remember that most of these studies are actually quite old, and the technology has evolved quite significantly over the period of time. And most of these studies were not standardized because of the guidance that were recently emerged, and also especially some of the studies that used the high-risk groups, and also just looked at the volatile rather than the TIVA. So a bit more recent cocaine database reviews stated that the use of bispectral index improves the intraoperative awareness, and it also enhances the recovery in the patients in adults with not only the high risk group but in the patients with the low risk group as well. If you remember about the NAP5 report, which is one of the largest national audit project, was launched in UK. That was in 2014, and the outcome of we were basically looking for the awareness in anesthetics and any risk factors associated with that. So they found the awareness of it was quite rare, like 1 in 19,000 anesthetics, but in some groups, like in the patients with the obstetrics or cardiothoracic anesthesia, or in the patients with the emergency surgeries, the incidence is relatively high. Interestingly, they found that the depth of anesthesia monitoring, although it was available, it was not used adequately or according to the guidelines. And they also found that 2/3 of the cases, the awareness occurred during the dynamic phases of the anesthesia, which is between the induction and the knife to skin, or after the end of the surgery and before the reversal of neuromuscular blockade. So this recently published article in British Journal of Anaesthesia actually compared the 5 different commercially available monitors, and they looked at to see the correlation between the index number that's generated by those monitors by the fast Fourier transformation, and they compare that with the raw EEG waveform. And they found that in 2/3 of the cases, there is a poor correlation between the index number and the raw EEG waveform. And that's why they recommended that the anesthetist should have some skill to interpret the raw EEG along with the index number. This was also reiterated in 2021 by AUGPI, in which they recommended, and it's kind of like a mandatory requirement for using depth of anesthesia monitoring whenever the TIVA is used along with the neuromuscular blockade. And they also recommended that even when the neuromuscular blockade is not used, you should consider using the depth of anesthesia monitoring along with TIVA. And this monitoring should be started before the induction, should be continued until the complete recovery from the neuromuscular blockade. And they also recommend that the anesthetist shouldn't rely only on the index number, but they also should actually have a basic understanding and knowledge of some of the basic waveforms in anesthetics, and including some of the fast Fourier displays like a power spectrum or density spectral error. So we know that for the safety point of view, it's required, but does it have any clinical benefits? So unfortunately, it's a bit of a conflicting evidence about the mortality reduction or reduction in the length of hospital stay, but there is a quite good evidence and emerging evidence on that it could reduce the post-op delirium and post-operative neurocognitive dysfunction, especially in the high-risk group. It also asserted when you're targeting anesthetics with depth of anesthesia monitoring, you're actually giving less anesthetics, which causes less cardiovascular instability and quicker awakening time. And it also has environmental benefits. So this article was published this year in British Journal of Anaesthesia, in which it's basically a systemic review and meta-analysis in which they looked at the processed EEG and with a couple of clinical outcomes. So they basically compared 3 groups. The first group had received lighter spleen of anesthesia, which is guided by the BIS monitoring. And the other 2 groups either received no BIS monitoring or received BIS monitoring but had a deeper level of anesthesia. So they found that although there was a significant heterogeneity, so we need to take the results very carefully, but they found that the BIS monitor with the lighter anesthesia group shows 4% reduction in postoperative delirium, and also there's reduction in the postoperative neurocognitive dysfunction 30 days after the surgery. They couldn't find any difference in terms of the mortality benefit or length of hospital stay. So if you look at the physiology, the EG waveform is generated by the pyramidal cells in the cerebral cortex. So these cells, when they depolarize, they produce a small electrical field, but this electrical activity is not sufficient enough or large enough to be detected by the surface electrodes. When about 50,000 to 500,000 of these neurons discharges simultaneously, then that produces a field potential, and that field potential can be detected on the surface, and that's what we call the EEG waveform. Unfortunately, even with such a massive discharge by the pyramidal cells, the voltage that they will get it on the surface in the microvolts. So this is compared to the EMG or ECG, which is in millivolts, and the frequency also overlaps with each other. So getting a clean EEG signal is quite difficult, and you need some sort of expert filtration and stuff in order to get rid of a clean filtered EEG waveform before interpretation. So this is a kind of a typical EEG waveform that you can find in a awake patient from his or her frontal cortex. It's just basically haphazard, small amplitude, high frequency, non-repeating pattern. And it's actually made up of not only the single waveform, but it's actually made up of several different frequencies, so starting from very low frequencies of 0.1 to 1 hertz to all the way up to 25 to 80 hertz gamma waves. Normally, you won't be able to see the gamma waves in the commercially available monitors because of the filtration process. So most of the activity that you can see is in the awake person is in the beta range, which is 12 to 25 hertz. When you give anesthesia, the beta wave changes into alpha and delta rhythm, which is typical for the propofol or TIVA-induced anesthesia. Theta waveform can also be seen in the patients with volatile anesthesia. We will discuss it later. As you know, that this unprocessed EEG is quite difficult to interpret, so we need some sort of interpretation. For that, it's a process or mathematical model is called the fast Fourier transformation, in which the complex frequency is deconstructed into the individual waveforms, and then we look at the power of the waveforms in these frequencies. So this is on the left side. So there are basically two domains that we're looking for. One is the time domain, and the other is the frequency domain. So this is complex waveform on the left side is deconstructed into its individual frequencies, and then over the period of time, they will look into the power in each frequency, and that's represented as a peak or a power graph, which is called a spectral power array or display. So on x-axis, it's a frequency, on y-axis, it's the power in each frequency. So in this example, the patient has received a very slow and titrating dose of propofol, and the effect of that is recorded on the EEG from the frontal cortex. So on the top side, you can see that when the patient is awake, you have a haphazard small amplitude beta activity, which is it's basically because of the haphazard, most of the frequencies are canceled with each other, and that produces less voltages in the EEG. As the patient had a propofol, you'll see that the amplitude increases, and this is because of the synchronization of the firing rate of the pyramidal cells. And that resulted in increase in amplitude because of the syncing. They're still in the higher frequency beta range, and this is called the paradoxical excitation or the beta arousal. And this is the stage when you can see the excitation phase of the anesthesia, which is normally not seen if you give propofol induction quickly. And then if you increase the propofol dose even further, you will reach to the sedation stage, in which the frequency started to slow down, and you started to see a little bit of undulation So this undulation is the delta wave, and this amplitude of these frequencies are increased even further, and the frequency decreases to alpha range, which is about 8 to 12 hertz. If you increase the profile further, you sorry. Hello, sorry. Can you mute your mic, please? I can. Thank you. Right. Sorry about that. So if you increase the profile even further, then you will see that you will reach the surgical anesthesia stage in which you have a clear delta waves, which is a slow 1 to 4 hertz waves. On top of these slow waves, you will have the alpha waves, which is about 8 to 12 hertz. So this type of pattern you need to remember whenever you are looking at the EEG under anesthesia, and this is the waveform that you're aiming for. However, if you increase the propofol even further, then you will see a bit more increase in the power in the delta waves. So you can see the amplitude of the delta wave increases, and the power shifts from the alpha waves to the delta waves. So this is even more maybe corresponding to the base levels of around 30. And if you increase the propofol even further, you will see burst suppression in which there is isoelectric EEG between the bursts. So the pyramidal cell stops firing, and then they're intermittently kick-started by the thalamic neurons. And finally, if the propofol is increased even further, then the pyramidal cells goes into the complete silence, which is called the isoelectric EEG. So you shouldn't aim for these two deeper stages of anesthesia because that increases the mortality and morbidity, and also so probably about the surgical anesthesia, deep anesthesia might be an option that you should aim for. So in this example, we are actually doing induction with the propofol. Again, the patient, this is before induction on the left side, and then the propofol bolus is given here. And you can see after a few seconds, there is this huge dip in the waveform. And this is because of the patient's blinking the eye and having a bit of excitation. And a few seconds later, you will see this waveform, and this is the beta activation in which the frequency is still high, but the amplitude started to rise. And then it's quickly followed by appearance of the delta and alpha pattern in which the waveform becomes slowed down, and there are two undulation. So this is a delta waveform, and on top of that you have alpha rhythm. And this is even after giving some more propofol, you will see a bit more alpha delta pattern established. And if you compare this one with the pre-induction one, the top EEG looks quite different from the one which is the patients with the surgical anesthesia. So this is a pattern that you should aim for your patient. Now, a bit of caution though, the alpha delta pattern, although it looks, it's there in both in young patients and older patients, but the alpha amplitude reduces with age. So this on the left side, you will see the perfect alpha delta pattern with massive alpha waves. But on the right side, with a similar anesthesia, you will see that patients with 85 years of age, the alpha wave amplitude is quite reduced. So you need to be careful. You can't see that pattern in the elderly population. And especially if there is a loss of alpha wave, it is associated with increased postoperative cognitive dysfunction and delirium. This is another interesting study that was a couple of years ago. That was they basically looked at the change in the low frequency pattern in the patients from awake to asleep pattern. So on the top left, if you can just concentrate here, this is the brain map, and if they have a higher frequency, a higher amplitude in the lower frequency, they appear as red, and if they have less voltages in the lower frequency, they appear as either yellow or blue. So in an awake patient with the eyes closed, you see the alpha delta pattern and the slow waves in the occipital region. But after increasing the anesthesia, if you see on the top right corner, that pattern has changed to the anterior or the frontal cortex. And this is called the anteriorization of frequencies that you can see among the patients who undergone anesthesia. The importance of this is not known, but it is thought to be caused by the thalamic neurons that causes a change in this pattern. Again, I'll just show you a little bit of burst suppression. How does it look like? So this is a real-time EEG. This is a patient having a burst suppression, which is quite deep, and you can see there's a spikes of EEG and then followed by completely isoelectric EEG for some time. So this is the burst suppression pattern, which is seen in the patients who are quietly deep, and that's why you should avoid and might need to reduce the anesthesia. Right, so let's talk about some more scenarios. So this is a patient who had a rapid sequence induction with propofol and rocuronium, and a minute later he was intubated. So the EEG electrode was placed before the induction, and you can see the beta activity here. Patient had a bolus, and 20 seconds after the propofol, you can see the perfect alpha delta pattern, slow waveform, and on top of that, there's alpha waves. So this means the patient is adequately anesthetized. Well, look what happens here. In 1 minute after the induction of propofol, when the patient had was like a stimulus of intubation, there is loss of delta waves. So EEG become kind of a more straight, and the frequency increases into the beta range. So this is called the beta arousal. So unless you're actually looking at the real-time EEG, you're going to miss this, and the patient could have awareness at that time. So the patient was deepened, and there is a reemergence of the alpha delta pattern. Again, there are two scenarios in which there is some disagreement between the index number generated and the raw EEG waveform, which is called the discordance among the numbers, or disagreement. If you see here, this is a raw EEG, which is, you can appreciate that is completely flat, so it's isoelectric. And if you see the base number is actually high, or relatively high for this. The reason is that the BIS has some proprietary algorithm, and it's not only single algorithm it uses. It uses several algorithms and switches between the different clinical scenarios. So when at this stage, the BIS is actually stuck to the algorithm with the higher threshold, and it after some time, it will jump to the lower threshold, and you will see the base number goes down to the 20s. So if you see this EEG waveform on the left side, you go irrespective of the base number, you need to reduce your anesthetic because you're quite deep. On the right side, again, this is disagreement. In this case, the base is actually low, and you can see the EEG is completely fine, is alpha delta pattern. So this has a perfect anesthesia, and you don't need to do anything in changing the anesthesia. And again, this is a different algorithm that the BIS is stuck with. And that's why it's really important to correlate your BIS number with a raw EEG. This is an interesting study that was done a couple of years ago, in which the researchers have given the succinylcholine to volunteers who were awake, and they looked at the BIS number. So on the left side, you can see that the patients or the volunteers were awake, and that was before giving the sucks. And you can see a beta wave, and there's some big spikes, which are because of the EMG. And then they have received succinylcholine, and soon after giving succinylcholine, a minute later, when the EMG is reduced to 0, but they still have a bit of fine fasciculations, and that is registered in the BIS, and they still give a higher reading. But look at on the right side, it's 6 minutes after giving the sucks, they're completely paralyzed, the fasciculations are gone. They still have fast beta activity, but look at the BIS, it's reduced to 52. And this is because the BIS also considered EMG in its algorithm. And when the EMG suddenly disappears, it thinks that the patient has deepened up to the deeper level of anesthesia. So this is a completely awake patient, and with a lower BIS number. So that's why it's really important, again, to look at the raw EEG waveform. So it's not easy for everyone to actually look at the EEG and then interpret that how it is go. So what you need to do is there are some of the special graphs that you need to understand. One of them is called the power spectrum display. And this is generated after the fast Fourier transformation. There's a couple of monitors that can generate that. One of them is the narcotrend. So what it does, on the x-axis, it gives you the frequencies, and in y-axis is the power in the frequencies. So instead of looking at this alpha delta pattern, as you're seeing it here, it's actually generate this type of graph. So this is a completely anesthetized patient with a surgical anesthesia, and you can see two spikes in this graph. One is the delta and the other is the alpha. So when you see this graph, this means that your patient is perfectly anesthetized. And this graph is a real time, so it changes very quickly. So you can titrate your anesthetics on the go. So again, we'll just discuss a little bit more about the power spectrum with propofol induction. So again, on the top, you see that is a patient is awake. There is a fine low amplitude beta activity. And on the power spectrum, you're not going to see any frequencies has a definitive increase in power. Soon after induction, you will see the beta activation, and this is quickly followed by delta power building, and that causes increase in peak in the delta range. And then the alpha rhythm also appears. And finally, when the surgical anesthesia is achieved, you'll see the alpha delta pattern there. Let's see what happens when you give ketamine to these patients. So the ketamine, because it's an NMDA receptor antagonist, and it causes excitation. So therefore, if you give the propofol, this is a completely and perfectly anesthetized patient, and this received ketamine intraoperatively for pain management. And a few minutes later, the patient's you can see there is a jump in frequency to about 15 hertz. And the monitor detected that was as an arousal, and that it gives you that the patient is waking up, which is wrong. So that's why you need to be careful when you're giving the medications and their effect on the EEG. Sevoflurane, on the other hand, produces slightly different kind of a graph on both the density spectral array and on the power spectrum. So on the top, you say propofol, you have a perfect alpha delta rhythm on the power spectrum, and on the density spectrum, which is on x-axis is the time and y-axis is the frequency, and z-axis is the amplitude or the power in that frequency. So you can see there are two powers, which are two red lines. One is here, which is around 10 hertz, which is alpha wave. Another one is in the delta wave, which is 1 to 4 hertz here. But look here, the sevoflurane. The sevoflurane, because it doesn't act on the GABA receptors, in fact, it acts on the T channels in the thalamic neurons, and that causes the activation of theta waves here. So that appears as filling of the gap between the alpha and delta. So there is no gap, as you can see with the propofol here. This is perfectly normal with the sevoflurane anesthesia. Another graph that you can see is the what you call the relative band activity. It also gives you kind of like an overall view of your anesthetic, that how you manage your anesthetics in that patients. On x-axis is time, on y-axis is the relative contribution of the each frequency band. So it's color coded. The lower frequencies are which is delta 1 in the blue, and the higher frequencies beta are in the white. So This is the patient who is before induction. You can see that most of the contribution is by the beta or white, and after induction, it changes into the blue, which is delta, and pink, which is alpha waves. At the end, again, you can see there is a decay in the delta and alpha, and there is gradual increase in the beta contribution. Again, this is a density spectrum array, which is a 3D graph. On x-axis, you will see the time. On y-axis is the frequency contribution. And the color is actually tells us that how much power is in each frequency. So if it's red, it has a higher power. If it's blue, it's the lower power. So this patient is maintained with the TIVA with propofol, and you can see there's the alpha delta pattern, which looks like a tram or train track appearance. There are two high band activities, and there is followed by relatively less activity in the other frequency areas. If you can see on the right side, when the patient has completed his surgery and the TIVA is stopped, there's a frequency change and to the higher one. So the alpha goes towards the beta, and then ultimately it becomes it's a mixture of frequencies, and that's why you won't be able to see power in any single wave pattern. And this is called the alpha roll. And similarly, there is a drop in the power in the delta waveforms, and that causes a delta decay. This is one of my patients who was anesthetized last month. I did. So he's 70 years old, and you can see that it's just nearly the end of anesthetic, so it was reducing the doses of propofol. And you can see that although there is a kind of a small yellow-orange pattern about at 10 hertz here, which is corresponds to the alpha one, but it's not nearly red as the delta here. And this again shows that the alpha waveform amplitude decreases with age, and then patient actually has a bit of dementia and had post-op delirium as well. The other things that I want to look at this is two more things. One is called the SEF, another is called the MF. So the SEF is this line is actually is called the spectral edge frequency. Which this is the frequency below which all 95% of the power of the EEG exists. So under anesthesia, it's usually around 14 to 15 hertz. And as the patient become lighter and started to wake up, it will roll upward, and that's why you see that the spectral edge frequency is 18 hertz here. On the other hand, the median frequency, which is less useful for interpretation of data, but it is basically tell us that 50% of the power is above this frequency and 50% is below this frequency. Again, this study that was done a couple of years ago, they compared the alpha power in the patients of different ages. And that clearly shows that in young patients, you have a quite high power in the alpha in 10 hertz. But as you get older, it's become less and less. And after 65 or 70, the alpha power decreases. And that indicates a vulnerable brain and increased risks of neurocognitive dysfunction. Now, if you have a problem with the EEG waveform, you need to go logically to find out that what's causing it. And so there are basically three factors that could affect the EEG waveform or the index number. So either the signal is coming from the brain, or the signal is coming from the patient but outside the brain, or the patient is coming from the environment. So the environment one is you need to be careful when you're putting the BIS monitor on the patient. Make sure that you clean the forehead with alcohol. Make sure that the BIS strip is adequately placed and pressed, and you don't monitor or don't recognize the things when the diathermy or drilling or hammering is happening. So if it's happening continuously, the base number, it usually gives you the signal to noise quality index. So if it's low, then obviously you shouldn't rely on the base or EG now. So what you do is normally you look at the EG waveform in between the diathermy or in between the drilling or hammering. But relying on the index number is quite, you need to be very careful with that. Again, when the patient's neuromuscular blocker is wearing off, you're going to find the EMG activity, which is usually detected by the neuromonitors. It gives you a false reading again. And also the movements, especially the eye movements. So if you're doing the eye surgery, because of the eye movement by the surgeon, it can give you abnormal EG patterns and the base numbers. And finally, you'll need to look for these causes that whether you're getting adequate drug delivery to the patient or not, or there's development of any cerebral pathology. Or in some patients, there might be genetically low EG, and it's quite difficult to interpret those patients. And that's why it's really important to start the monitoring before the induction, so you have a bit of idea that how that patient was doing. So I would recommend that you should go to read this article, which gives that, although it's a relatively old article, but there's quite a decent discussion about what were the condition that causes the bispectral index to go up and down and how to fix it. So in summary, that there are several advantages of using the EG monitoring and depth of anesthesia monitoring in anesthesia, but there are certain limitations as well. And there are several factors that affect not only the raw EEG, but also the processed EEG waveform. And that's why it's really important that the basic understanding of the EEG patterns and the factors that affects them is known to the anesthetist. And if you go to neuromonitors, then the real-time fast Fourier transformation displays like DSA or power spectrum would give you a bit more information without doing some mental burden. And finally, if you have a problem, if your base number or EG waveform is abnormal, then you need to go to the systemic approach to rule out the causes of abnormal signal. So I think I'm finished a bit early, but thank you very much for the invitation. And we have got a lot of time, so I think I can take some questions, and we will discuss the things which are probably missed here. Thank
Thank
you.
you so much, Dr. Faisal. We got an earlier question from Dr. Naseem, and he asked, how can the integration of artificial intelligence in the depth of anesthesia monitoring contribute to both the prediction of and personalization of anesthesia management, including the automation of the anesthetic agent adjustments, and what challenges might arise in ensuring the accurate and reliable outcomes in the clinical practice?
This is a very nice and very brilliant question, and actually there was quite a lot of talk about happening about AI, not only with the EEG, but its general integration into the healthcare system. So at the moment, I think it's in the development stage. So the research is going on. You're getting a couple of some new publications on that. But there's several challenges to reliance on the AI on that. The first of all is the legal challenges that when you completely rely on AI, then who's going to be responsible for delivering anesthesia or dealing with the problems like awareness? So this is one of the things. And the second is the monitors that we have at the moment are not capable enough to deal in real-time AI stuff. So if you look at the computers, especially in NHS or even in your own hospitals, these computers will take like probably 5 minutes to boot, to wake up. So those computers are not useful enough for the daily interpretation or integration with the AI. So you need really good computer systems And also, you need to develop some methodology and processes to make sure that the AI, although it looks and it goes into it is not completely autonomous, and then it should be someone responsible for what you call is the legal responsibilities for that. But it's the things are underway, and I'm hopeful that in the next 5 or 10 years, you're going to see there's a lot of integration happening, maybe a bit early as well, in all the systems.
Okay, so do we have any other questions from the participants? I would request all the participants to kindly either write in the chat box or unmute yourself to directly ask Dr. Faisal Jafar. In the meanwhile, those who do not know how to fill in the feedback form, so we usually share these feedback form at the end of the session, and when you fill it up, then we look at the attendance, and those who have attended more than half of the lecture, they are given the e-certificate on their email address through which they have signed in. So I have one more question, which was sent to me directly, that this is for you, Dr. Faisal, that if we are using target control infusions, especially in those cases, what is the recommendation for TIVA? Should we use it, and should we need to monitor the depth of anesthesia in such patients or not?
So the recommendation from AGBI, which is the Association of Anaesthetists from Great Britain and Ireland, is that from 2022 is that it's mandatory to use the BIS monitoring whenever you're using TIVA with neuromuscular blockade. Without neuromuscular blockade, they suggest that you should strongly consider using it. But no one actually recommends using it for when you're using it volatile. In fact, the current studies which are available shows that when you're using the end-tidal monitoring with the volatile versus the BIS monitoring, there's not a huge difference. So the number of awareness or wakening up or the complication rate are the same. So yes, with TIVA, with neuromuscular blockade, you need to use it every time. And you should consider even when you're using it with TIVA without neuromuscular blockade.
Even if TCIs are used, target control infusions?
Yes. So there's a false safety about the TCI. First of all, the TCI is based upon the studies in the different volunteers, and that doesn't actually correlate well with the whole population. And the second, there quite a lot of things go wrong. So you will see that some of the patients who were getting propofol TCI of 2.8, and they're perfectly fine. And there's some of the patients who are requiring a TCI of 5 or 6 or even higher, but they were still moving. So, and if you check their BIS, they will be quite high as well. So there is quite a different variability of the patient's response to the propofol TCI, because the TCI is actually the mathematical model is not actually monitoring anything in the patient's itself. And the second thing, there is a couple of things go wrong. You could have a disconnection from the cannula. Your propofol might not be effective, or there's some other issues. So there might be issues with the drug delivery system that might be detected, especially when the patient is having neuromuscular blockade. If it's not, then obviously they can start waking up and start moving. But with neuromuscular blocker, they might be awake and aware, but you may not be able to find it at that time.
Thank you, Dr. Faisal, for such an extensive answer. So there is another question, that if a patient develops intraoperative ischemic stroke, do we get any change in the EEG waveform at any point in time, or any change in his BIS number? Can we monitor that ischemic stroke event intraoperatively?
So the BIS is not designed to be used as a cerebral pathology monitor. And the stroke also depends upon that which area and how big of the area is affected. Obviously, if you have a massive infarct, then it will be detected as a sudden loss of EEG activity or into isoelectric form. Or you could have a seizure like epileptical issues. But for For general strokes, you won't be able to get that one through. There are other monitors available. One of them is the near infrared spectrophotometry. Again, that's again tells you about the oral brain oxygenation. But it's you shouldn't rely on the EEG monitoring with it unless you have obviously 32 channel. The full head is with electrodes, and then you are detecting every part of the brain for that. So this is with the normal base, you are just checking the frontal lobes, either right or left, or some of them you can use it on both sides in dual channel one.
Thank you, Dr. Faisal. So there is another query that at times the depth of anesthesia monitors can fail to detect the consciousness under anesthesia, primarily because they rely on the frontal EEG. So in such kind of a cases, can we benefit routinely from raw EEGs and a spectrogram, or do we need to have certain other monitors to actually check them?
So whenever using TIVA, this is the base is not 100% reliable indicator for the awareness. The raw EEG again depends upon the many other factors, and as you can rightly say that it's just monitoring the frontal lobe. The awareness is pretty uncommon. It's about 0.1% of the cases, and there's several factors that are involved in that. That's including that even if you're not using the EEG correctly, I mean, if your EEG electrode is not correctly placed, or if you're getting a high impedance, so there's so many things that you're thinking that you're getting a good number, or you're getting a good EEG, but you might not be able to get a correct signal until you discuss or like rely on those factors that we have already discussed. So that's why it's important. And all of the recommendations says that do not rely only on the BIS or EEG. You still need to rely on everything. Like for example, if you're doing TIVA, make sure that your cannula is visible to you all the time. Make sure that you use it with a dedicated circuit. Make sure that their one-way valves are there. So there are lots of other things that you need to consider along with monitoring the EEG for reducing the awareness. But against, I mean, if you're doing this one, at least you can stand in the court of law to defend yourself that you have done every possible thing to reduce it.
So I think this is also answering Dr. Saira Asgar's question, and she has also appreciated your response to the questions that have been asked. But she's asking, what is the next better anesthesia monitoring method in the setups where EEG is not available, especially in the peripheral areas of the Pakistan or the smaller institutes?
So I'm not sure that how frequently the TIVA is being used in those areas. If I believe just use the volatile for those areas if you don't have the EEG monitoring. The EEG monitoring itself is not very expensive. There are lots of monitors that are available now. Some of them are really cheap. So is a consumable, which is causing a bit more problem, but you can, I've seen the areas where you can reuse them several times. But again, if the monitoring is not available, then I would say that stick to the volatile, especially when you're using the neuromuscular blockade.
Thank you so much. If we have any other questions, you're more than welcome to ask. Dr. Faisal is here. It was such an informative talk, Dr. Faisal. We got to learn relatively newer modalities, as well as you had mentioned about the arrays and the other stuff. So most of the hospitals, tertiary care hospitals, even in Pakistan and in good setups, whether they be private hospitals or now some of the public sector hospitals, they are also using the BIS monitors and the other spectrograms. But the arrays, I don't think that they are available overall in Pakistan. But it was as per we had asked you to tell us about the recent guidelines, so it actually enhanced our knowledge on the topic. Any more questions from the participants? So the feedback form has been shared on the chat box. Kindly fill in the feedback form so that you can get the e-certificate. We also have with us Dr. Akhtar Waheed, who is the senior most anesthetist in the group. And also, I'm just looking at the PSA President Karachi, Dr. Shabbir Jumani. But I think he is Yes, he is there. So I would request both of the our seniors to have a comment, and then we will close the session.
Dr. Shabir Jawani is not asking. I'm Dr. Akhtar Waheed. Did you make any inquiry from Bolan, your alma mater, where you had your MBBS?
Regarding, sorry, what?
Regarding your Bolan Medical College, where you graduated. What about that medical college? Has it got any BIS monitor or not?
I think I've seen this. I'm sure there's probably on the chat as well. He can probably answer the question. Amjad, are you here? He works there. He's the head of the department. Yeah.
Thank you, Faisal. I'm here. And to answer that question, actually, we don't have any BIS monitor here in Balochistan or in Quetta. So, but I used to use it as I was in Malaysia. So for cardiac surgery, all of the even patients were monitored for the BIS. As you know that during pump, when the patient is going for pump, at that time, we don't know, and we don't have even a predictable flow of the isoflurane or any other sedation agent. So for them, it is actually mandatory here over there. So otherwise, in Balochistan, we don't have any BIS monitors.
It is nice talking to the HOD of Bolan. That's how I'm trying to remember a very senior anesthetist who is no more with us. And he was a poetic background. And I do remember meeting him when we attended a conference. And I was staying in Serena. What is his name? Do you remember? I cannot remember now. He's no more with us.
Yes, actually, he was our late Niaz Nasir Sahib.
Yes, Niaz Nasir. I will never forget him because I'm still alive, but he left us a long time ago.
But his memories are still alive in our hearts and minds.
Oh, I see. Very good. Nice. Niaz Nasir Sahib. He presented me a blanket, which I still have here in Karachi. It's a gift from Balochistan.
That's so nice, sir. We also have other seniors, and before having Dr. Shabbir Jumani, can I also ask them? We also have Dr. Aziza Hussain and Dr. Ihtisham, Dr. Kashif Ali Maiman from Hyderabad. These are all seasoned and senior anesthetists of anesthesia community. I welcome again all of you. So if you have any comments for Dr. Faisal, please share with us.
Well, Dr. Faisal, very informative talk, definitely. And it reminds me of my older days, my earlier days in anesthesia, when our fingers used to be our best monitors. And now we have come in the era, where we can find these things. And I'm very happy to know that there are many BIS monitors in Karachi. Well, many of them still don't have, but a time will come that these facilities will be available as well. And very informative talk. Thank you very much, Dr. Faisal.
Thank you.
So when we don't have any more comments and suggestions and as well as questions, so thank you, Dr. Faisal, for joining us on PSA Karachi Online Lecture Series. I'm really grateful to you for giving us such a time, and I'm also thankful to all the participants who have joined us at this hour from 8 to 9. Thank you so much. Thank you,
Thanks
Dr.
for having
Faisal.
me. Thank you.
Thank
Bye-bye.
you so much. Okay, take care.